Hi. Welcome, everybody. If you haven't taken a seat, feel free to take a seat and get settled at your tables. So I just want to welcome you all to our Hope for Mental Health community here at Saddleback Church, and also to any of our viewers online. We're so glad you can join us today. This is a safe place where you are welcome to come and find support and journey together and learn from one another. And so we're just so glad that you're here. So I do have a few brief announcements. One thing I wanted to announce is that you may or may not have heard, last year, Kay and her team and Saddleback Church hosted a retreat called the Breathe Retreat. And if you have a child of any age who lives with mental illness, so you as a mother, this is specifically for mothers, you are invited to Breathe, a restorative weekend for mothers of children with mental illness. And this is happening on May 1st through 3rd at our Rancho Capistrano Retreat Center. And this is a gentle 2.5-day retreat at which you will be provided with whole person renewal through nature, music, deep conversations with other mothers, personal counseling, spiritual direction, equine therapy, art therapy, and yoga. It's an intentional time to commune with God and connect with other mothers who are on a similar journey. We actually have members here in our community who have gone through that retreat. So if you have any questions, please come find me and I'll try and get you connected. But you can register if you just go to saddleback.com/breathe. So we just wanted everybody to know about that opportunity. Some of you may have come with needs of various sorts today. So we wanted you to know we have a resource table at the back of the tent with books and resources for you. We also have one of our prayer ministers here, and she would love to pray with you at any point during the event. We also have, during the teaching portion, we have some Q&A cards on your tables. And so if questions arise as David shares with us today, please write those down, and we're going to take some time at the end of the event to try and answer those questions. We'll get to as many as we can. So that is the announcement. So now I just briefly would like to introduce you to, we will be hearing a story from one of our members of Saddleback Church here and a member of our community, Andrea Lendine. She's going to be sharing just her heart with us, and I'm so excited to hear more from her. And then we'll hear our teaching portion by our pastor of mental health, David Mandani. And so David currently serves as a pastor of mental health here at Saddleback Church. But his extensive background includes working as faculty and a community board member for the Graduate School of Social Work at Azusa Pacific University, as a vice president at the Orange County Rescue Mission. And David has over 20 years of experience in direct practice, executive leadership, consulting and training, board governance, and church leadership. And in addition, David has worked in both emergency and inpatient programs, coordinating care. David was actually diagnosed with schizophrenia at the age of 18, and so he offers a really unique perspective as a person with lived experience, and he's just loves sharing the hope that he has found through Jesus Christ, and he's going to share a little bit of his journey with us today, even throughout the teaching. So I'd like to welcome up Andrea.
Good afternoon. My name is Andrea Lendine, and I'm very grateful to be here today. I've been asked to share a little bit about my journey of freedom from anxiety and depression, so I'm very just honored to be asked to do that. So thank you for having me today. I started this journey about 10 years ago, and what felt like the absolute bottom of my life at that time. And that difficult time has become a platform for healing, learning, and growing that led me to drastically improve my mental health, to change careers, and to give back to the community like I'm doing today. So the encouragement I want to offer is that you can have a full, joyful, and productive life, and that a diagnosis is not your identity, and that even the hardest times can be used for good. So I have childhood memories of depression and anxiety, probably as young as 7 years old, and it became much worse as I became an adolescent. But I did not get help. Instead, I kind of internalized that struggle. And this created a pattern of isolation and the need to act like I had it all together. As an adult, my career and relationships distracted me from realizing that I had a serious problem with my mental health. When my life became unmanageable and the depression became overwhelming, I succumbed to a stronghold of a deep depression. Now, at that time, I did not have a relationship with Jesus because I felt unworthy of being loved and ashamed. Ashamed that I struggled with my mental health. And I was feeling bad about myself. The lies that the enemy fed to me was that I was all alone, that I was stuck in my circumstances, and that taking my own life would actually end the pain. But the pain finally outweighed my fears, and I allowed my family to take me to the hospital in 2008. An extensive history in the hospital revealed that symptoms and behaviors of anxiety, depression, and mania were prevalent. And this led the psychiatrist to diagnose me with bipolar disorder. And I was beyond devastated, and began to believe the lie that life as I knew it was over and I would never get better. I was terrified and sad, angry and confused, overwhelmed, scared, discouraged, and just so fearful of stigma. As I attended the groups in treatment and spent time with my doctor and therapist, I had to open my mind to learning and not focus so much on denying the diagnosis. I began talking with the other patients and felt accepted and supported. I truly believe that God was with me at my absolute bottom. I found myself face down on the ground, and all I could do was roll over and look up at him. Within a week out of getting out of the hospital, I was baptized in the ocean. Surrendering to Jesus has completely transformed my life, and I have not been hospitalized since 2009. I remember thinking, I don't want to get baptized during the worst time of my life. But God has shown me on numerous occasions what an incredibly important and vital decision that was, and that his timing is perfect. I can see God's hand in all of it. I was never alone, even when I was isolated, depressed, and afraid. It's been a challenging road, but God has helped me manage my mental health and has provided the best doctor, therapist, and medicine. In 2011, God called me to start sharing my story to offer hope with patients and their families at the hospital where I've been treated. At the same time, he led me to Saddleback Church and Celebrate Recovery, where I discovered my safe place to be myself, slowly process the painful challenges of my life without any judgment, and grow in my relationship with Jesus. It is by no coincidence that I am sharing my story today as part of the Saddleback Mental Health Ministry. And as of February 24th, 2020, I will be celebrating 9 years in Celebrate Recovery. My old story of mental illness robbing me of my life has been deleted by God, and he has changed the narrative to a path of mental wellness and helping others that struggle as well. God revealed part of his plan as that I was to go back to school, change careers, and further seek his will. By 2015, I accomplished a master's degree in clinical psychology at Azusa Pacific University. It's been an honor to serve men, women, and children that are on their own mental health journey. My life has been forever impacted by these amazing people that have trusted me with their story and allowed me to learn from their experiences. But the coolest part is that I now have certainty that God has a purpose for my life. Another unexpected blessing has been the opportunity to serve in ministry. I have co-led a Christian women's group that focuses on seeking freedom from anxiety and depression by strengthening a relationship with Jesus and trusting him to do the necessary inner healing work. by opening up with God in such a way that he could reveal what happened within me and change me from the inside out has brought tremendous freedom and healing that only God could do. I have learned that it was a courageous act to seek treatment and intentionally change the direction of my life. My diagnosis and my past are not my identity, rather the truth of what God says about me. I'm feeling led to rephrase this. A diagnosis is no one's identity, no one's. It's rather the truth of what God says about us and who he made us to be. My family and friends have been my vital lifelines in my recovery, and I'm forever grateful for their support. This once chronic isolator is now an advocate, an encourager, a survivor, a thriver, and a true believer that God brought me out of the ashes to transform me from the inside out and teach me to help his people. Although there were times that were extremely painful and frightening, I am now coming from a place of healing, and I can say that I am thankful for my mental health journey. I am not cured. I will have difficult times, but I have learned a lot along the way and met a lot of amazing people. My life is filled with joy and peace despite any diagnosis. Currently helping on my daily walk is Philippians 4:6-7. Do not be anxious about anything, but in every situation, by prayer and petition, with thanksgiving, present your requests to God. And the peace of God, which transcends all understanding, will guard your hearts and minds in Christ Jesus. Philippians 1:6 states, and I am sure that God who began a good work within you will keep right on helping you grow in his grace until his task within you is finally finished on that day when Christ Jesus returns. And to me, that hope means that everything is going to be made right, and God is not done with us yet. My encouragement is to take one step at a time, which can be extremely hard. Take one step towards community. Take one step towards telling somebody what you're going through. Take one step towards what brings you joy. Taking steps can take you in a completely different direction. You are loved. You are not alone. There is hope. Thank you so much for letting me share my story. So now we want to encourage you to share it with each other and have a little table talk time. You can share what's on your heart. We also have questions on the screen that can, help you through your conversation. So please take advantage of this time. We'll get back together in about 10 minutes.
I hope that you have enjoyed your time together during our table discussion question time. Let us now move into the education portion of our day today. Today, we will be covering how to navigate a mental health crisis. And I know that there are a lot of questions, and we're not going to cover a lot of territory, but please have your 3x5 cards. We'd like to try and answer as many questions after this session. So basically, we're going to journey together today in the next 30 or 40 minutes on what it might look like to move before a crisis and what you need to know, what's it like during a mental health crisis, and what do you do after a mental health crisis. I do need to acknowledge before I do this training that our system of care, you probably agree, is pretty broken. And today will be more about discovering what you might need to know at each stage of a crisis. And just so you know, this training is actually created for people with lived experience, like maybe some of you or myself. It's also for people who have loved ones or family members living with mental illness, or laypersons, or church staff looking to walk with others as they move through a mental health crisis. So let's start pre-crisis. What happens before you move into a major crisis, going into the emergency room and into a psych hospital? We'll start with mental illness. Mental illnesses are medical conditions that disrupt a person's thinking, feeling, mood, daily functioning, and ability to relate to others. And so if you haven't before experienced mental illness and you're starting as a family member or friend, or you're yourself wondering, well, what are the signs of mental illness? Oftentimes mental illness or disorders are associated with significant impairment or distress in maybe your social, occupational, educational, or other important activities. So in other words, due to the symptoms of mental illness, maybe with depression or anxiety or psychosis or bipolar disorder, the person begins in varying degrees to struggle with their relationships, maybe at home. Maybe you start to miss work or have a difficult time wanting to go to work. Perhaps schooling might begin to be limited if you're in college or in high school. Or maybe you might find yourself in other activities that you found enjoyable before, like going to the movies or hanging out with friends, begin to get affected. Typically, what you'll find is that symptoms persist more than 2 weeks on average to really begin to get alarmed and realize, I think I might need to get help, or I think my loved one might need to go and get some help. And as moving towards a crisis, we need to understand what it means. And for today, the definition we're going to use for mental health crisis is this. A mental health crisis happens when a person has suicidal thoughts, or maybe wants to hurt someone else, or a crisis may be an acute state of maybe deterioration. So you might be hearing voices, or those are what we call auditory hallucinations, or you might have visual hallucinations where you're seeing things that other people don't see. Or you might have delusions, or what we call unshakable irrational beliefs. Or a crisis could mean that because of the symptoms of mental illness, that you're unable to address your basic needs for food, clothing, and shelter. And so how do you prepare? How do you prepare for a mental health crisis? Well, first of all, you want to learn all you can about the illness you or yourself or your family member might have. Second, you might want to find out about insurance benefits. What does my insurance cover around mental health and wellness? And maybe identify safe people or support systems in which you could tap into. Like here at Saddleback Church, we have small groups, we have support groups, we have some other ways in which you can get continued support. You certainly want to learn to recognize the early warning signs of relapse, such as changes in sleep, or maybe withdrawal or social withdrawal. You're sleeping in the room, you're locking the door, you're sleeping 18 hours a night. I remember myself, as I was not well, I would sleep for 18 to 20 hours a day in my college dorm room. Maybe your hygiene begins to, go, you have inattention to that, or you have signs of irritability. I'm giving you a lot of factual information, but I just want you to know, as Andrea shared so beautifully, that your illness is not your identity, and that there's no shame when it comes. It's not your fault when that does happen. These symptoms do come. But what you do want to do in preparing for a mental health crisis is you basically want to understand what are the symptoms of the mental health diagnosis that you or your loved one has. And for those of us who are seeking care and have been journeying in your wellness journey and being in recovery, maybe a visit back to your psychiatrist or case manager or therapist or support group, or even a friend could help prevent a full-blown relapse and avert a crisis. And one last area you might want to prepare for before you end up in a hospital is a crisis kit. This concept is really neat in a sense that kind of like when someone's going to have a pregnancy, they're preparing for a baby, and they have a little bag that they take to the hospital. You could also have a bag or crisis kit available. So you could have changes of clothes, or a phone charger, or phone bank, information and history. I'll talk about that in a minute. Maybe some hygiene items, because you might be there for quite some time. And so what are your expectations? You've gone from being out in the field, maybe in your house. You've gone from maybe a park or something. You move through a crisis, and now you end up in the emergency department of a hospital. What are your expectations the first time going in? Well, first of all, your loved one may not be admitted. You're coming in for help at the hospital. You're hoping that a professional can provide some kind of care, and you may not be admitted. And we'll talk about some options in a moment after that, if you're not admitted. You might stay in the emergency department for a long time. It could be 3 hours, it could be 6 hours. I've heard up to a day and a half and even longer, so be prepared with the emergency kit. Your insurance eligibility will maybe determine where your loved one or you yourself are admitted. Or bed availability may not be there, it may be full. So that means you might have to transfer to another emergency department in psych hospital. Be aware that it's commonplace that security guards will be present, and it might feel daunting or intimidating that someone's watching you or your loved one, but they're looking for safety. And oftentimes, and as hard as it is, sometimes restraints might be placed on you or your loved one, and it might feel dehumanizing. From the professional staff's perspective, they're just looking to increase safety for everyone involved in the process. Or it might be really crowded in the emergency department. Might be really crowded in the emergency department. And so be prepared to expect these kinds of things happening as you end up in the ED. And so while you're in the emergency department and you come in and you're like, oh boy, I need some help, what will happen when you share with a nurse that you're having a mental health crisis is that a mental health evaluation will be done by a professional when you're brought into the emergency department to determine if you meet criteria. Your loved one or yourself meets criteria for an involuntary hold. I'll talk about what that criteria is in a minute. But one thing I really want to touch on, and it's on your table, is what we call a portable health record. It's about a 2-page document. We also have a packet online. We'll give you the link if you're watching on Facebook Live. And this is very important to include in your crisis kit, because what it has, it's got history, it's got current medications, it's got a lot of data and information that what we call collateral information, or information being shared by the loved one or you yourself getting care, that can help bring and fast track the care that you're getting in the emergency department. And so I'd encourage every one of you to make copies, fill this out, download it, and carry it with you in your crisis kit should you go into emergency department. Also, you may be asked during the evaluation, if you're with your loved one, you may be asked to leave during that time. And so what is the criteria? Well, criteria that you're being evaluated on is criteria of an involuntary hold, or the evaluation is also known as a 72-hour hold, or 5150. And so this includes evaluating if there's probable cause to believe that a person is in danger to yourself or a danger to others, or maybe gravely disabled, meaning you can't take care of food, clothing, and shelter because you're just not doing well. And so a professional will sit down and interview you. And grave disabled, let me give some quick examples because I know we get a lot of questions around what that means. And it just means that maybe you have some irrational beliefs or symptoms of illness that the food is poisoned, so you're not going to eat, or you have no plan for shelter from the snow if you're going to be discharged from the emergency department. Or maybe you're running around without your clothes on in the streets, and that's what's brought you into the emergency department. A quick note during the evaluation is that oftentimes as a loved one, as a parent, as a friend, and you bring someone in, that person may present differently. When I was in the emergency department receiving care, I presented differently. I was laughing and hearing voices. Other people might be able to hold it together, and they may present differently than all the hard work that you had maybe in getting your loved one outside in the field before coming into the emergency department. Or perhaps maybe because the illness is so strong that perhaps you might be what we call poor historian, and you're not, if you're coming in with lived experience, you're unable to really provide some history and some information and answer all the questions that people are asking you during the psychiatric evaluation. And so that's why it's also important to have your portable health record ready to provide some more collateral information. Now, if you're out in the field, if an evaluation is done by a peace officer, what we call a sheriff, a police officer, or a crisis assessment team, here in Orange County, call them your CAT team, where a professional goes out to your house or where you're at to do an evaluation. An involuntary hold application may be written in the field by the professional. And so from there, you'll be transported into the emergency department, and you'll be seen by psychiatrists who will confirm the hold. And so essentially what you're going to find is that all the information I'm sharing here today is related to Orange County and Southern California and the state of California. I'll be covering some laws. But just for your information, a lot of people come into the emergency department for a mental health crisis in different ways. They come in through a peace officer. They'll come in maybe by ambulance. Family or friend will take someone in, or maybe there's a transfer from another hospital, emergency department, because there are no beds. But understand this, that when we say an involuntary hold is written in the field, and it's common to be transported, if you're in the field, by ambulance and with restraints. And so be prepared. Just again, the whole factor, and I'll say this time and time again, is the safety piece is so important for everybody involved in this journey and process. And so when you come to the emergency department, a decision will be made in one of two ways. You either can come in voluntarily as someone is saying, gosh, I'm having a tough time, maybe I need to go to the emergency department for care. Or maybe you may be held admission-wise involuntarily. So voluntary admission at a psychiatric hospital is basically going into the emergency room or psychiatric facility on your own will. You have the right to discharge at any time, unless a hold is written during the time that you're in the emergency department. Voluntary admission, by the way, here's a little bit for the family that might be involved in providing care. Oftentimes, the biggest goal is to reduce the risk of traumatizing the person who is moving into an emergency department. And while you may have a lot of good and well intentions to try and get your loved one into care, it could also be painful for the person receiving the care. And so a forced approach oftentimes is less of what you want to happen, and you want the person to come in voluntarily. Because what will happen is in the future, it'll become a trigger point. And you're going to say, oh, would you like to go to the hospital? You need care. You need care right now. They're going to be like, why would I want that? I don't want that. I don't want that. For me, it was traumatizing. I had to work through that in my own journey and process. So safety is always first. But how do you approach someone who is in a crisis about voluntary admission? We talked about last month about this kind of dynamic of choice and safety and things like that. But, one way that I know, even here at Saddleback Church, is a concept of empathy. You could use empathy. Say something like, I notice you haven't been eating or sleeping lately, and then you describe the symptoms. I noticed that you've been isolating, and it's been very difficult for you to really get out of bed, and would love it if you can get some professional care. Would you come with me? Would you be willing to go voluntary to get seen? I've seen a lot of success in that approach because you're walking with people as opposed to forcing people into care. Involuntary hospitalization is also known as commitment, and it's when a legal document is written to hold the person by a designated evaluator. And this can be a person on the crisis assessment team or CAT team, police officer. It can be a professional designated by the County of Orange, or a mental health professional or a member of the attending staff in the emergency room. And a hold just really means that you are now legally detained and unable to leave according to the law, and that the driving value, I'm going to say a couple things over and over again. The driving value is safety. Is this person safe? Are you safe? We want to promote safety. And so what happens is that the individual will be held initially for up to 72 hours, particularly for evaluation and assessment. That's 3 days. And it could be noted that only a psychiatrist can discharge a patient from the hold, and may even discharge a patient and has a permission to discharge an individual before 3 days if they see that it's necessary. The emergency department also will then do what we call a blood draw for the patient being admitted. And one reason in doing so is really just to determine if there are any substances like methamphetamines or drugs or alcohol, any physical problems that might be causing any risk or harm before you're transported into a psych unit or psychiatric hospital. And so the goal really is, from a medical standpoint in the emergency department, from a blood draw, is to medically clear an individual for transfer to a secure psychiatric unit. Now, I just want to stop, and I just feel like I need to say this, is that a lot of this factual information can be really triggering. And a lot of this factual information can be very difficult in terms of people's experiences. And so I just want to encourage you and let you know through the Q&A time that we want to offer kind of like a holistic view of care after we get through this time of teaching together. Now, if a person does not meet legal criteria for an involuntary hold, and they're going to be discharged they will be discharged from the emergency department. So you come in from the field, you think you're going through a crisis, you end up in the emergency department, an evaluation is done, and it's determined, oh, okay, you don't meet criteria, and so therefore I'm going to need to be discharged. The question then becomes, what do I do? What do I do as a person with lived experience? What do I do if I'm discharged after an evaluation and I have a family member or friend that's there? Well, there are several things that I'd love to recommend along the way. First, you want to explore your options for residential treatment programs, or what they call RTCs. And so the hospital, when you look at a psych hospital, you think of it as kind of the highest level of care, very acute, and you're providing intensive treatment. There are some lower levels of care or less acute ways to get help through partial programs, intensive outpatient programs, or other services in your local area as needed. If you look at your packet on your table, and you also look online at the link that we'll post, we have a document on levels of care that spells out what it means to participate in all these different levels of care. And I'll cover these treatment options or these levels of care at the end of our presentation. Another thing you want to do is maybe you might want to schedule an appointment with a therapist and a psychiatrist. And this is your first time coming into an emergency department, and you haven't yet experienced what it might be to maybe or maybe not have a mental illness, and you're not sure. Great ways to connect with a therapist and psychiatrist to rule that out and to get an evaluation in an outpatient basis. I think also at a very important point is you want to also give the Suicide Prevention Lifeline phone number to your loved one, to families and friends involved. That's 800-273-TALK. That's 800-273-TALK. If you're in a helping profession, if you're here to provide care for your loved one, or you yourself are maybe living with mental illness, I'd encourage you to put that in your phone. Put it in your phone. You never know when you need it. Put it as a contact, Suicide Prevention Lifeline. Now, one thing I do want to spell out is oftentimes people ask, well, what's a psychiatrist and what's a psychologist or licensed therapist? The difference is that a psychiatrist does medication management. You won't get a lot of time to process. It'll be an interview, maybe an hour and a half an hour, to kind of determine what needs are there and the prescribed medication accordingly. A psychologist or licensed therapist, however, is more involved in the process and processing through things going on in your life. It's typically an hour a week, sometimes 2 hours a week. It's also known as talk therapy, and they use research methods in terms of how they support you from a professional standpoint. Another thing you can do if you're discharged after an evaluation from emergency department is to increase contact as soon as possible with a therapist, psychiatrist, or any other person providing care or licensed therapist. I know I'm really driving this home because what I'm going to talk about later is continuity of care. The care doesn't end when you discharge from an emergency department. You certainly want to dispose of any and secure any means of danger, so there might be weapons or there might be pills. You certainly want to dispose of any means in the household where the individual is. And as appropriate, you do want to notify your friends and family to create a 24-hour, maybe no suicide watch team, and as appropriate. Again, your goal is to increase safety and reduce risk. And what you'll find then is that with suicide, if you're talking to your friends and that's a topic that's happening with your loved one or you yourself, just understand that here at Saddleback Church, we know that there's an incredible amount of stigma around mental health, incredible amount of stigma around suicide. And so it's okay to start the conversation. You have permission to go ahead and talk about it. At this church, we're known for saying your illness is not your identity, as Andrea shared so beautifully earlier, that it's okay to have these hard and difficult conversations because we know that stigma oftentimes becomes a barrier, an issue that keeps you from getting care. If now you're in the emergency department and you realize, I've been placed on involuntary hold. So once you're medically cleared and the hold is written, you'll be transferred to a psychiatric unit, either at the current hospital or at another hospital. Hospital staff are in charge of coordinating the transfer, and so you can work with the hospital staff. And a transfer to another hospital will be done by ambulance if they're full or if your insurance isn't particularly fit within that hospital's what they take. Another document that we're, again, posting on the link online as well as on your table is a list of psychiatric hospitals in Orange County. And these are hospitals with contact information. It's a treasure trove because it's always important to know where you need to go or where you might end up going and if your insurance matches up according to care. I will say, do not let insurance stop you from going in for care through a crisis. Okay, let that be taken care of after. What's important is you take care of the crisis right away. And so lack of bed availability and insurance also could be a factor as well, though, in where you're going to end up receiving care. So now that you're moved into the emergency department, an often question that people ask is, well, what about confidentiality? Well, the U.S. Department of Health and Human Services enforces the federal privacy regulations commonly known as HIPAA Privacy Rule. That's HIPAA. And HIPAA stands for Health Insurance Portability and Accountability Act. HIPAA requires most doctors and nurses and pharmacies and hospitals and nursing facilities and other healthcare providers to protect the privacy of your health information or your own privacy when you're getting care. And what that means is that according to HIPAA law, this federal law, you may not be able to visit your loved one or due to their right for privacy. So what are some ways in terms of looking at confidentiality? Your loved one's in an emergency room moving into a psychiatric hospital, and you're not sure if you could have contact. Well, for best results, you might want to ask your loved one to sign an authorization for release or release of information of the medical information to you during the emergency room evaluation or admission process. An authorization for release form, every hospital has them, is when you go in for care. They're going to give you a packet to sign, and the person with lived experience will just, or person in crisis will say, I want this person to be able to see me. I don't want this person to be able to see me. I want all these people, and they'll write down their names. If you end up on that authorization for release form, then you can go and visit the individual while you're there. If maybe the individual refuses, you can ask the staff to continue asking your loved one throughout treatment in hopes that they will change their mind as their condition improves. And so if you are living with mental illness, you basically have the right, and you can choose during intake who interfaces with you during your hospital stay. If you're a loved one or friend calling in to find out how things are going, and you're not on that authorization form, the hospital will respond and basically say something to the sorts of, I cannot confirm or deny that your loved one is receiving treatment as you call in for care, because you're not listed on the authorization form. But let me give you a few quick tips, having worked on both sides, of how to maybe navigate that a little bit better. Number one, maybe have someone close to your loved one, a friend or a cousin, contact the hospital's psych unit where your loved one is or your friend, and request that the staff ask your loved one to add them to the authorization form. The second their name comes on there, the doors open up. And so now you have a person who's in between you that you might be able to have some communication. Second, if you're on the list but need someone else on the list, maybe someone else in your family, visit your loved one or your friend and just say, hey, listen, would you please add so-and-so to the list on the authorization form? And that's another way in which you could get on the authorization form. Now, I've talked a little bit from the angle, mostly from the angle of people who are providing care or advocating care. But I think it's also helpful as well to give some encouragement to people who are living with mental illness. Like I myself spent 2 weeks in an inpatient psych hospital. And so there's some insights. Many of us here in this room and online have as well. And looking from experience, I want to give you some encouragement here as to some of the things that would really help, really be helpful in the care that's being provided. Understanding a few things. First, I'd encourage you to increase your willingness to participate in the treatment and the care that's being provided. I know that with symptoms of mental illness and all the pain that's there, it's important to really be as honest as you can when hospital staff are working with you. So for example, if a nurse asks you in the unit, hey, how's that medication working with you? Be honest about maybe some of the side effects that are going there so that the doctor can make adjustments accordingly and really assist you with your goal in your wellness and recovery journey. Understand that a team of professionals are there to assist you. And I know there are a few bad birds out there that just aren't caring and difficult and harsh and whatever experience you've had. But overall, a lot of professionals come into this field because they feel a sense of call, a sense of mission, a sense of wanting to do something right. And so there are people who are good out there. I wouldn't throw the baby out with the bathwater. There are people who are good out there who want to assist you. And I would take advantage of the many tools accessible to you during the day, during your time and stay. So what does a typically daily routine look like? You've gone from the field, you transition into the emergency department, and now you're inside a psychiatric hospital or inpatient stay. Daily routine would look like 3 regular square meals that are provided. You'd be invited to participate in individual therapy, or group therapy. You'd be meeting with a psychiatrist and communicating with a psychiatrist what might be going on with you. And this is particularly a medical model, in a sense, of how care is provided. Medication disbursement by the nursing staff. You'll find that you'll meet with a social worker to talk about where do I want to go after I discharge? What's going on with all these other areas of my life, maybe with housing? And care can be provided or support referrals. You'll meet with an occupational therapist, and some places have outdoor spaces. The psych unit that I stayed in years ago when I was not well had a basketball court. It was a lot of fun to play basketball while I was not doing well. And then there are rooms. Just know that oftentimes they're shared. The rooms are oftentimes shared. So if you're someone who's coming in to visit, I'm going to lay out some expectations for visiting hours, because this can be sometimes for some people for the first time very difficult process to walk through. Visiting hours are typically limited in time. They're limited because they're usually set during off-program hours. And rules are often pretty strict to ensure patient safety. And so you're coming into a secure unit where safety has always been a high risk. And so be prepared to adhere to the visiting rules. I'd encourage you to go online if you're going to visit your loved one for the hospital and see what those rules are. But some might say that you can't wear shoes with shoelaces, or your belongings, it's often might be searched for objects that pose a safety risk. And again, it could feel really dehumanizing. Some hospitals will even have a wand like you're in an airport. But I'm just really preparing you and to know what to expect so that there isn't, that big shock factor when you go in to care for your loved one and visit your loved one. Now, what is very important when someone is in a psych unit and they're being held involuntarily, or they go in voluntarily and they're receiving care, is request a family session. That's what you can do as someone on the outside. Request a family session. It's also known as a treatment team meeting. So if the authorization for release has been signed and your name is on the document in the chart, request a family session with a psychiatrist, the social worker, and the nurse. And this is how you do so. Simply call the psych hospital, ask to speak with the charge nurse of the psych unit or social worker, and let them know you'd like to have a family session. You'd like to come together and powwow and touch bases with the treatment team who's providing the care for your loved one or friend. And it's recommended, by the way, that your approach be polite and collaborative in nature. I know that there's a lot of difficult feelings that's there, from anger to being really upset or grieved. There's a lot of emotions going on moving through a crisis, but I just encourage you, you can go a long way posturing in a collaborative nature. And so what do you do when you come in and meet with a psychiatrist and the social worker and the nurse or the charge nurse? What questions do you need to ask? Well, certainly you want to ask the treatment team the following. You want to ask them, what is a diagnosis, and what does a diagnosis mean? When someone comes into an inpatient unit, a provisional diagnosis or a temporary diagnosis is often provided, and it's not uncommon for that provisional diagnosis to change during the patient's stay, because as a person moves through their wellness and journey and comes down from the crisis, you're going to find that symptoms change and things like that. Not all the time, but sometimes. You do want to ask the treatment team the course of the illness and its prognosis. And you also want to ask the estimated length of stay. Estimated length of stay is basically how long that person is going to stay in the unit before they discharge. Estimated length of stay changes based on medical necessity and is often set by the psychiatrist or doctor. And this is important to know, because if you have 4 days before you know someone's going to discharge, as a parent or a family or a loved one, you might say, hey, I want to look for some treatment options before this person discharges. And so I want to advocate, I have this much time. And I'll talk a little bit more about working with a social worker who could provide a lot of those options in a minute. You certainly want to ask the treatment team symptoms causing the most concern and what they indicate and how they're being monitored. And you also want to ask medications prescribed. why these particular medications have been selected, the dosage, the expected response, and what are the potential side effects, and what's the plan if side effects do come into play. It is common for medications to change while you're staying in a psych hospital. Oftentimes they'll titrate up or move up, or sometimes they'll come down based on the doctor's assessment. And so it could be a very difficult process for the individual receiving care, because you're having to really find that place of reducing symptoms, reducing side effects, increasing the maximum therapeutic value of the medication. And so from this medical model, this process really takes some time and when you're adjusting medications. Now, if you look at the treatment team and the team that is really engaged daily with your loved one or with yourself, a sample treatment plan would include this: individual treatment, group treatment, medication compliance. You want to stabilize the individual's mood, increase coping skills, eliminate psychosis. And psychosis, or symptoms of psychosis, really just means unshakable, irrational beliefs, or hearing voices, auditory hallucinations, or visual hallucinations. Those are the most common ones, the auditory. You also want to improve insight and judgment. And this is very important to understand, because insight is usually tied to an individual's understanding of what circumstances brought the individual in. They want to know at what level a person recognizes that they are living with a mental illness. And if you know that you're living with a mental illness, then you can manage and you can cope with it. If you don't, it's called anosognosia. It's a symptom of illness. There are some resources about that in the table, in our resource table in the back, and if you want to ask about that, we have some resources and answers for that. Another way is they want to eliminate the suicidal ideation. And certainly through your whole time during the inpatient stay, there is this monitoring and adjusting of medication. So you're trying this medication mix, or you're trying that, and it's having this effect. And do not become discouraged if you're living with mental illness. You're like, oh, this sucks. This is hard. My body is taking a beating, and I feel lethargic, and I'm tired, and I'm gaining weight. I'm sensitive to the sun. My head feels fuzzy. And they're not doing an experiment on you, really. Oftentimes what you're going to find in this collaborative effort, as I encourage you to work with a team, is they're really, really wanting to get good, honest feedback on how your care is being done, what are the symptoms, and how are we reducing them through the medication management. So how long? How long will my loved one, or how long will I be on an involuntary hold? Well, that we can reference the Lantrum and Petrus Short Act of California, or LPS laws. The LPS Act concerns the involuntary civil commitment to a mental health institution in the state of California, and it refers actually to sections 5150, 5151, or 5152 of the Welfare and Institution Code of California. WIC law is what they call it, WIC law. And this bill, or what they call this bipartisan bill, was signed into law in 1967 and came into full effect in 1972. So I'm sure many of us have heard of 5150 or 5250 and so on. And so what that really is referencing the laws around involuntary commitment for the state of California. So 5150 is known as a 72-hour hold. It's the detention. If you look at the language on the PowerPoint, that's language developed in the 70s. And so it's basically you're going to be held for 72 hours if you meet the legal criteria. You're a danger to yourself, or maybe are suicidal, you're a danger to others, or you're gravely disabled. You can't take care of yourself because of the symptoms of mental illness. We also have, laterally, a law that has passed 5585. That's also known as the Children's Civil Commitment and Mental Health Treatment Act. And this is a children's version of a 72-hour involuntary hold. And it uses the same legal criteria, danger to self, others, and gravely disabled, for detainment or holding someone. After a 5585, or 3-day hold, for children, what typically happens is that you follow the same pathway pursuant to the LPS Act, so 5250 and so on. For today's training, I'm really just going to cover 5150 and 5250 because that's the majority, if you would. I don't have enough time to really go into the depths of all the other codes that are out there for WIC law, but majority of people fall and their stay is within 1 to 2 weeks. So 5250 is also known as a 14-day hold. What it is, it's a certification for intensive treatment. So you have your 3-day hold, and then that ends, and you realize, oh, I need some more help. And so another 14 days would be added for persons who meet the legal criteria of being a danger to self, others, or gravely disabled because of mental illness. And so a certification review hearing, also known as a probable cause hearing, will happen. And what that is, it's a facility-based hearing, or like a time where everybody gets together, for persons who have a 5250, also 5270, which I won't cover. And the hearing is to determine if the psychiatric hospital has probable cause to keep the person or detain the person for the remainder of the 14 days. And so the certification review hearing is held within 4 days of the person being placed on the 3-day hold. If no probable cause is determined, the person can either stay, I'm going to stay here voluntarily, or I want to discharge against medical advice. So essentially what I'm saying is that when a 3-day hold ends, a 5150, and a person still needs further treatment, a 5250 is written, and the hearing at the hospital is held within 4 days. Now, basically what happens is this hearing is hospital staff representation, typically a charge nurse or a social worker or a psychiatrist, and then you're going to have a patient with a patient advocate usually, and then from the county you're going to have what we call a mental health hearing referee. And so y'all come into a room, you're not in a court or anything, it's held typically on the unit, and you go into a private room and you'll have the referee sitting there, and the hospital will share, well, this is why we believe from a factual standpoint that the person needs to stay. And then the patient will say, this is why I believe I need to go before 14 days is up. And the patient advocate will help infill and advocate as well. After both sides are shared, then the referee will say, I think that you can be discharged, so you'll win the hearing as a patient. Or the other alternative will be, oh, I think that you do need to stay for a longer term. And so if you win your hearing and there's no probable cause as a patient, you could again voluntarily stay, or you can discharge against medical advice. And now we're moving towards the concept of being in an inpatient hospital, psych hospital, and we're talking about discharge. And I do want to really highlight something very, very important on the next slide. Because as we begin to discuss discharge options, I want you to remember and to know that according to research, the suicide rate after discharge from a psychiatric facility increases dramatically. And so a study was done in a meta-analysis of 100 studies and actually 183 patient samples. The post-discharge suicide rate was approximately 100 times the global suicide rate during the first 3 months after discharge. 100 times. So it's important to have an aftercare plan. It's important to talk about where are we going and what's going to be the next step after moving on. Continuity of care is the goal. For me, I had 6 relapses over 7 years, and I think that, and this is my personal bias, that you can probably reduce the amount of time of suffering post-discharge if you had some kind of plan, because my experience was different, and recognize the need for continuity of care. And so let me give you a few tips when you're working with discharging from an inpatient psych unit. First of all, and I will say this again because it's important, is you want to secure any deadly means. So that might be any weapons, any medications, any knives. Very important to secure that within where your loved one or friend is staying. You work with the family members or friends where they're at, or roommates. Second, you want to discuss the level of care. Where are you going to go after you discharge? And this is best done in collaboration with the person who is on the unit, person with lived experience. You want to have that discussion. Where am I going to go after discharge? Those levels of care, which are residential treatment centers, partial hospitalization, intensive outpatient, or basically psychiatrist and a psychologist in outpatient care. You could reference the levels of care, again, online on the link or the papers that we've given you. Now, how do you know what level of care that your loved one or you yourself will fit after discharge? Well, it's determined mostly if you're working with a social worker and the treatment team. So say, for instance, you're having a family session. You're asking them, where is the best place for me, or where's the best place for my loved one to discharge afterwards? Because I want the care to continue. You've gone through many transitions. You've gone from the field into emergency department, that's a transition. Emergency department into a unit, that's another transition. And from the unit, you're now going out into a lower level of care or back out. Very important to understand that you don't want to forget that continuity is very important in terms of continuing the care and support that is there. And so as you work with a social worker to determine that, you're looking at the levels of care that's there. Perhaps maybe the social worker will recommend a partial hospitalization program. They will work with you to get the paperwork and work with your insurance with what options they know. Or you could do your own research, which is not uncommon, to figure out where do I want to go. Maybe a residential treatment center, and you're doing your own research as a person who's on the unit, or oftentimes your loved one, for your loved one. Now, understand that insurance oftentimes determine what programs can be accessed, and so that's often a very difficult thing to navigate. I'd encourage you to talk to the social worker, because the social worker is really focused on sitting with you and saying, hey, you know, if your insurance doesn't get this, here's what I know might also be an option for care. As you continue your discharge, now one thing you want to really focus on is get your the prescription will be written and it'll be on the discharge paperwork. Make sure that you are sure to get that prescription filled and that you continue taking the medication as you make that transition. You also want to get a copy through the hospital, the medical record that the person with lived experience would write or would sign off on that if you'd like. And the whole goal is to get that into the hands of the psychiatrist once you get to an outpatient setting. Now, insurance does require all inpatient hospitals, psych hospitals, to have your loved one make an appointment with a psychiatrist and therapist. That's one of the conditions of discharge. That's just the way of care. Or actually have some kind of link to an outpatient treatment setting like a partial or an IOP before you do discharge, because we know that wellness outcomes increase as continuity continues. We know that if you fall through the cracks and you don't get care after discharge, that it's likely that you're going to have a very rough time in your journey going forward. Now, as I wrap things up, I really want to talk a little bit about a chart that's up here, or what we call the continuum of care. And so if you look to the farthest left of the chart here, you're going to see severe symptoms. And so that's what we're talking about in inpatient psychiatric services, right? You're there, the symptoms are severe. Now, when you discharge, your goal is to move towards the right. And so the next step, if you want to see less acute care but lots of support, would be what we call a partial hospitalization program. Typically, you're living at home, and you come in for 9 to 5 p.m. Lunch is oftentimes provided, depends on the place. And partial programs, you have oftentimes seeing a psychiatrist and an individual therapist. You're having group therapy. There's a lot of ways and things that you're learning in terms of coping and things like that, and you're preparing to move to a less intensive unit. Sometimes people will go into the next phase, which is to the right. The symptoms are reducing towards the green, called an IOP, or intensive outpatient program. So at this point, sometimes you might be able to work. So you're doing a program from 6 to 9 at night, 8 to 12 in the morning, maybe 1 to 4. And so that's the next option. There's an IOP, and you're commuting from home. Sometimes you get 2 weeks or 3 weeks based on insurance there. And then where it says recovering or it's green, most often you're seeing a psychiatrist and a therapist. And we know, according to the research, and that's what insurance often requires, that when you couple medication management with a psychiatrist, with a therapist or process, and there's compliance or the motivation to get that care, that oftentimes you do see those wellness and stability outcomes begin to increase. And then you have it's not on the chart, is what we call a residential treatment program, RTCs. They're 30 days, 60 days, 90 days, or even longer. They often are, it's not uncommon to go to a residential treatment center where you fly over state lines or go over state lines for people to get care. So these are all the options that are available once you do discharge. And it's really important because I'd say, if anything you walk away from this, are a couple themes. Safety, 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 continuity of care, and just be very, be informed about what you know is ahead of you. Prepare, once you go into an emergency room and an inpatient stay, start planning for that discharge. Work with a team. If you're with lived experience, be honest, participate. I gotta tell you, it's like night and day sometimes. When I've seen people move from I don't want to do care here to, okay, I'm gonna give it a shot as hard as it is. So at this time, we're going to move into our 20 minutes of table discussion. And if you do have any questions, we have 3x5 cards that are on your tables. We'll collect those in a few minutes, and we'll move on to our final portion of our Q&A. Okay? Thank you.
Hello, everybody. So sorry to have to interrupt your table time. But we are now going to move into our Q&A portion of the afternoon. And so we received a lot of questions from you. We'll get to as many as we can today. But thank you so much for your active participation, and we hope that you will learn something from this time as well. So we actually got a number of questions, and I think this is a topic that comes up over and over. And it's a question of, my loved one, there seems to be something going on, but they don't see it. And so how do I get my loved one to maybe be open to treatment or help? And so there can be two components going on. There can be some of you asked about denial, and some of you other ones asked about like they're not even aware that there's anything going on. So I know that anosognosia is something that David has shared about before and that he's also experienced, and he would like to share a little bit on that if he would.
Sure. But before I share, I do want to just say that Todd is joining us. He is a pastor of pastoral care here at Saddleback Church. He's also licensed, and he's also my boss. So
And my
so
boss.
I have to behave. So in reference to your question, this is a question that we often get asked is, what if my loved one does not want help, but they're living with mental illness? And let's dig a little deep into here, and then I'll go into the resources. So there's this clinical symptom called anosognosia, and it's most quite often associated with psychosis or schizophrenia and bipolar disorder. Not in every situation, but that's where it's mostly clustered. And anosognosia is a symptom that really just means that the person living with mental illness doesn't really understand that they're living with mental illness. And so it's like me going up to an individual and saying, Christina, you don't work at Saddleback Church. And
Yes, I do.
Yeah, yes, you do. See, and so you can go back and forth until you're blue in the face, but you just won't agree. And why is this important, this insight? Why is it important to understand anosognosia? Because if you do have the insight that you are living with mental illness, then you can manage it, then you can own it, then you can move in your wellness journey. And so how do you reach someone who is living with anosognosia? Before I answer that question, there's denial. Anosognosia is not denial. Denial is knowing that there's a problem, but you're just pretending it's not there. Anosognosia is, I really don't believe that I'm sick or I'm living with mental illness. There is a resource by Dr. Amador Javier. He's written a book called I Am Not Sick, I Don't Need Help. And you can find it on Amazon. You could also find it at the back of our resource table here in the back of our 10.3. And he uses what he calls a LEAP method, which is an evidence or research-driven practice. Listen, empathize, agree, and partner. And you could really learn a whole lot if you get this book. But it's instead of saying, let me force treatment, or let me force you to take your medication, everything relies solely and incumbent on your relationship with the individual. The trust that's garnered, the connection that's there, the empathy that you're providing, the alliance that you're building. And so I'd strongly encourage that. You could also check out the website for Dr. Amador Javier. There's a whole lot of resources there as well. So,
Thank you, David.
Yep.
There were actually two questions around this topic, and I just have to say my heart really goes out to whoever asked these. So there were two questions around an individual needing to seek help for themselves and being aware of it, but being a professional in the field or being a parent and being concerned if I seek help and maybe I become hospitalized, or if I'm a professional in the field and I become hospitalized, how will that affect my life, maybe my child or my career? So how would you speak to that?
Okay, well, I work in mental health, so obviously my journey is what led me to go back to school and become a mental health professional. But I think for me, working in the field, the most important thing is self-care. Whether you struggle with a mental illness or not, it's hard working in mental health care. It can be, definitely deplete you of energy, but you have such care and compassion for people, but it's challenging sometimes not to like take that on, and the weight of that and the stress of that. So for me, I had developed a relationship with my supervisors that I work with in mental health. So if there were times that I maybe didn't feel the best, I could have a conversation with them and take care of myself. But I think ultimately you have to do what's right for your family. So it's a little bit tricky because we live in a society that still struggles with a lot of stigma, and I've kind of faced that head on, that I'm not ashamed of what I'm dealing with. It's not something that I wear on a badge and say, my name is Andrea and I have bipolar disorder, but it's certainly something that I have discernment of who I'm open with about that, and just taking into account of the situation. As far as seeking help, maybe one of you can to speak to that.
Yeah. You're talking about sharing testimony?
More like, I know I need help. I can even sense it as a parent or a professional, but I'm afraid of the repercussions of that. But that's a very fine line to walk.
Yeah. Typically, obviously, I shared empathy. Empathy is so powerful in your relationships. And I think if you were to look at, I need help, I'm very vulnerable, I'm living with mental illness, I'd encourage you to take that step of courage to get the help. And oftentimes people say, well, do I need to tell anyone? We're going to be, the stigma is there. And you know what? I just say it's up to you to tell what's going on biologically. And so, I think that when it comes to your medical information is how I'd frame it, it's up to you as a family or a person with lived experience. You're living with mental illness. It's up to you if you want to disclose it. I don't disclose. I could say I'm living with prediabetes because I am, but it's the right of the person to choose and to determine some of the risk and also some of the benefits as well. I'd encourage you to survey that before you share. So.
Thank you, David. We also had some questions around, we know that when there's a loved one living with mental illness, it impacts the whole family and the whole system. And there was a specific question around parents. So if my child is living with mental illness of sort, what types of supports might there be for me as the mom or the dad? So I'm wondering, Todd, if you could speak to that.
Yeah, no, I'd love to talk about that. So for me personally, I've got two boys that are on the autistic spectrum. So awesome, right?
Leonard. Yeah.
And also one of them had just extreme OCD type behaviors in junior high, counting stairs, walking up and back and forth between doorways and things like that. And it can cause a lot of disconnection in the family, right? All of a sudden now this one person becomes the center of everything, and you can easily forget the rest of the family members that are around. And it was important for us when we went through this, for my wife and I, number one, to make sure that we were connected in community. Isolated by ourselves, we each handle things differently. And I tend to be the talker, and my wife tends to be a little more the stuffer, right? So not a good combination, right? I'd talk, she didn't want to hear it. She wouldn't talk, I'd want to hear it. So that can get you, kind of get you disconnected. So really, it was really important for us to have a community of people that understood around us that we could talk to. And go through this with together. So that was really important. So we had a great small group who also had some lived experience with their own children, which was great. And we also plugged into resources to understand and learn more. It's one thing when you're in the middle of it, you get overwhelmed, and so all of a sudden now you got doctor's appointments, you got this going on, and people telling you all this stuff. It can be confusing. And so it was important for us to do our own research and get into some support groups and things like that around us for that to happen. So I would highly recommend you do that, because having those things makes a huge difference in how you approach that. When the family's filled up as the primary support system, then I'm better now for my loved ones who need help. If I lose myself in the midst of it now, that support system breaks down, and it really can become a problem then for the loved one that I want to help. Because if I run out and get depleted, how can I be there for them? So I'd really recommend that you get involved in those kind of things.
Sure. Thank you. That's good.
You get some claps.
Mhm.
Anybody else?
Go ahead.
Okay. All right, so here's I think a really interesting question. So we really encourage treatment here and as a part of the holistic wellness journey. But here's a question around, can you have a relapse even taking or being on medication?
So I learned a really important lesson that stopping medication without a doctor's supervision is a really bad idea. And my family could come up right now and give that information to you directly that when I was first diagnosed, I had started trying different medications with the psychiatrist in the outpatient program. I was feeling much better, getting kind of stable, and just learning about this new diagnosis that was terrifying to me, but I felt safe for the first time, like being in an outpatient setting and meeting people that were going through journeys of their own. So as I got out of the outpatient program after about 5 weeks, I didn't have a strong aftercare, which David kind of touched on. The aftercare is huge because the continuity of care is really what's going to help set you up for success beyond just that initial treatment. Initial treatment is kind of like the triage. Okay, it's like trying to find a, direction and then go on that direction. But after the outpatient experience, I was no longer in a hospital environment and found a psychiatrist in a different city that was closer to my home. And unfortunately, this person couldn't remember my name, let alone my diagnosis or what medication I was taking. It was really, I was new to receiving mental health services, so it was frustrating. But because of that disservice, he wasn't properly monitoring my medication. And I was feeling better, so I started not taking the medication appropriately that the doctor in the hospital had prescribed. So the typical feeling better, I don't need these medications, went off the medications, and that actually sent me into a full-blown mania. And so whereas my first experience was an outpatient experience, my post-outpatient experience going off medication without a doctor's advisement, I went inpatient. And in order to, anyone that's experienced coming down from a mania, I had to take higher levels of medication to get me to come back down to regulate. And so I really don't remember much of my experience in the inpatient setting. So that was really scary. So what my family learned from that is really have to advocate for yourself as far as good aftercare. If there's a psychiatrist or a therapist that's really not a fit or is not meeting your needs, you have every right to fire that person and go find someone else, because although that person led me to someone better, unfortunately I had to go through the experience of a mania. So I would say, just from my own experience, that just trusting, if you're comfortable with a doctor and you feel like your needs are being served, trusting them to take you through the process of finding the right medication, because it's different for everybody. Just like someone can eat dairy and someone can't, like medication is going to be different for everybody. And so really finding that appropriate balance takes a long time, and the patience to do that is like perseverance. It takes a while to figure out what's going to work for you, but ultimately, I've been on the same medication, up and down a few milligrams, same medication for 10 years, because my doctor and I found kind of what works for me. So.
And, my experience, I'll just share a few reasons why I stopped using medication against a doctor's advice. Just so that you're aware, maybe of some of the dynamics with your care. For me, I didn't like the side effects. I gained 30 pounds. I was sensitive to the sun. And when I came off my medication, it spinned me off into a relapse. I also thought I was better because the symptoms went away. And then little to find out later that I should have stayed on my medication. Those are probably the two top reasons. There's probably some other ones, but what I would say under a doctor's orders and prescription, work with your doctor that you trust. And, I think with medication, that's living with schizophrenia, that's a key point of bringing me back to a place of wellness. It wasn't until I asked the question of myself after 6 relapses, I asked myself, what's making me feel better? And I realized, the medication does. And then I thought, what's better, the side effects, the cost, or the benefits? I can actually talk to someone in a very, relatable way. And I thought the benefit far outweighs the cost of the side effects. And so that's how my journey was, medication was very important during the process. So.
Thank you, too, for sharing that. We also had a question around, so at the point of crisis, that individual may be experiencing it could be the psychosis, or it could be suicidal ideation. And so as a loved one, you're trying to help, your loved one. But are there any tips that you would say, having the police come and interrogate you and see if you meet criteria, that can be a very scary experience. So coming alongside that individual, are there any tips on how to care for that individual who's experiencing that crisis?
I would say start with least restrictive. You start with the prevention lifeline, the suicide prevention lifeline, which is 800-273-TALK as a starting point. And then here in Orange County, we have something called a centralized assessment team, or CAT team, where they'll send out a licensed therapist who can do a mental health evaluation like we talked about during our training today. And that's less restrictive, right? Because someone can come out to your home and maybe evaluate, is there criteria? And then the next step is, hey, I'd love to invite you to come in with me to an emergency department voluntarily, and maybe even get voluntary treatment as well. That's the next level. And really, the forced approach where it's like, no, I'm not willing to go, that's obviously when that's the most pinnacle piece of a crisis, where maybe perhaps it might be appropriate, I don't know, to involve a peace officer or someone who's involved. Peace officers are trained. You never know what you'll get, but certainly it's out of your hands, because I wouldn't frame it as I'm going through this crisis. The second there's a suicidal thought involved, it becomes a medical issue from a medical model. And so the care is provided accordingly. So if that's helpful. So.
Thank you, that's really helpful. We also had a question around just the relationship between mental illness and substance uses, co-occurring disorders, and that's something that can be very tricky to treat. So Andrea, I was wondering, because you do work currently in a setting that treats co-occurring disorders, do you have any thoughts on how would we, even just how to understand maybe that relationship between the two? Between substance use and mental illness, just how to understand co-occurring disorders.
Yeah, so it really is specific to the client that we're working with. I don't work in primary mental health. I primary substance abuse. So there's always a level of co-occurring disorder, whether it's depression, anxiety, so many different disorders that can present. The tricky thing is that sometimes substances can, cause certain symptoms of mental illness. So even in, the DSM, where, the diagnoses of different disorders, there's a component of, is this, because of substances that these, symptoms are occurring. So it's kind of tricky with that. But it's really customized care. So understanding kind of the precipitating event of the patients, and why is it that they're seeking treatment, what their goals are, what's their history. There's a complete biopsychosocial that's done when they first come, which I really enjoy doing. It's just really getting to know the client and understanding, biologically, psychologically, socially, everything that's going on in their lives. I work with people that are very successful, high-level executives, at the same time, people that are unfortunately homeless and seeking help. So mental illness and substance abuse does not discriminate. So it's really specific to that person, and looking at them, like you mentioned before, like a holistic lens. Like it has to be considered, mentally, spiritually, emotionally, relationally, financially. Everything about that person is what we have to learn to understand. So, and oftentimes substance abuse is a maladaptive coping skill of the mental health that they're struggling with. So whereas, one person with anxiety, they may lean towards, alcohol because it's going to give them that sense of calming down, or someone that's struggling with depression, they may take a methamphetamine or something that's going to make them feel up better. So it's really looking at the person holistically and who they are as a complete person coming in as to how you can start working with them and setting goals and having the proper treatment plan moving forward.
Thank you. I love that, really considering the whole person and even maybe some of the root causes of what's going on with someone. So we do need to wrap up. So I'm going to ask one last question to one of my bosses. We're meeting here at a church, and we believe God is good. And yet, each one of us here has either directly experienced or someone in their life struggling with a really painful, maybe ongoing chronic mental illness, and it's painful and it's confusing. And so there's a question that was asked, why does God allow my child to suffer like this? So Todd, would you like to just speak to that briefly?
Yeah, I'd love to. That's such a great question because, we want to look at God and say, okay, well, you could just sort of zap this and take this away and not have this happen, and why is this happening to me? And I can tell you, I've wrestled with that myself as it related to my boys, right? Why did this happen? There's got to be a cause, right? We're always looking for what those things are. And I prayed several times, Lord, why me? Right? Why us? Why does this have to happen? Because your dreams change, right? You think they will anyway, right? Because you don't know what's coming forward. But one of the things we know about the Lord is, first off, he can handle those wrestles, okay? So being real with him is important, and it's an important part of the process of having a relationship with God. He wants to hear those things that we're struggling with in our heart. The other thing, too, is the fact that his heart breaks, too, for our pain. He really does. We live in a fallen world, right? If you haven't looked around, things don't go quite the way that we want them to go. I'm aging. I don't like that. I'd like to have everything kind of just stay the same or go the way I want it to. But unfortunately, with our fallen world, there are those consequences that we suffer as a result of that, just living in this space. And so, unfortunately, there's not easy answers to this. But we know that God loves us. We know that he's created us for a relationship with him. And we know that his heart breaks for those of us that break as well. And so we can trust him and lean into him and bring all that tough stuff to him. So there's not an easy answer to wrap that one up. But one of the things that I know is because of the Lord, he's gotten us through all of that. And because of that, we've been able to just minister to our kids and just go through that process. And I tell you, I wouldn't trade it for anything because it's brought us closer together and closer to him.
Thank you, Todd. I'm actually not really answering questions, but I do want to really briefly speak to something that Todd just triggered my memory. I was speaking to a mother on the phone recently who had lost her child to suicide. And she would just pour out her heart to me. And as I was praying for her, I got this picture of this dark, dark cave. And she was sitting in it, and she felt so alone. And then I saw Jesus walk in just with a little candle. And he just sat there in the dark and just brought his comforting light and his presence. And I think there are no answers to these losses. There's no answer to so much suffering, but there is a person who is with us in the dark, in the questions. So sometimes it doesn't mean we can resolve it, but we don't have to be alone in it. So I just wanted to share that. So I'm just going to give a few closing announcements. Just briefly, we do have our dear Lucy here today. She would love to pray with you at the back. And also on Wednesdays from 10 to 12, you can come in, and she'll be there. Sometimes some other prayer ministers. We in Ministry Office 1, and we'd love to pray with you also during the week. if you would like. We do have a number of support groups, around 40 of them actually. So you can find more information on Saddleback's website, all different types of needs that we seek to address and support you in. You can also volunteer here at the monthly community, and you can just email us at mentalhealth@saddleback.com. And also, Andrea shared her story with us today, and we had a live offer of a story as well. And we really want to hear your stories because we want to hear what God has done and where you're at and what you've learned. So you can email those also to us at mentalhealth@saddleback.com. And then just a quick announcement, next month we will be hearing, on March 22nd, we will be hearing from J.P. Moreland. He is a world-renowned philosopher, and he teaches at Talbot School of Theology. And he's authored and contributed to over 95 books, but he actually has a very personal journey with debilitating anxiety. And he would like to share on the information and treatment and guidance, just what he has learned on his own journey of living with anxiety and finding hope in the midst of that. So we hope you can join us here or online on March 22nd. So now I'd just love to pray for you all and before we dismiss. So Lord, we know that your word says that you are near to the brokenhearted and you save those who are crushed in spirit. And your word says that we can come to you for rest, comfort, and healing. And so Lord, I just pray a blessing of protection and peace over each one here today and watching online. And Lord, I ask that you would cover them with your love, your mercy and grace, and your strength today. And I pray this in your name, Jesus. Amen. Thank you.
Thank you.